You have been tired for years. Not the kind of tired that a good night of sleep fixes. The kind of tired that lives in your bones. Your joints ache in the morning in a way that does not make sense for your age. Your hair has been thinning and nobody can explain it. You have been to the doctor, maybe more than once, and every time you left with the same answer. Stress, or aging, or anxiety, or just life. You left with nothing. Here is what nobody told you. There is a disease that affects Black women at 3 times the rate of white women. It attacks the joints, the skin, the kidneys, the heart, and the brain. It mimics so many other conditions that 63% of people who have it get misdiagnosed first. And on darker skin, one of its most recognizable signs looks completely different than the textbooks show. Doctors who are not trained for that difference miss it, and when they miss it, the disease keeps moving, silently, until it is not silent anymore. That disease is systemic lupus erythematosus, SLE, and most people simply call it lupus. And if you are a Black woman and nobody has ever talked to you directly about this disease, about why your body faces it at this rate, about what the real warning signs look like on your skin, in your blood, in your daily experience, then you are in exactly the right place. Here at Marcus Webb, Black Health Truth, we do not give you the generic version. We give you the version your biology actually needs. Today, I'm going to walk you through exactly what lupus is, why African ancestry carries a specific and documented biological relationship with this disease, what the medical system keeps missing, what is happening inside your body when this disease goes undiagnosed for years, and the specific steps you can take right now to protect yourself and the women you love. We are going to cover 4 things. First, what SLE actually is at the cellular level, because understanding this is what gives you power. Second, the genetic and hormonal reality behind why Black women carry this risk at higher rates. Third, the diagnostic gap, including the specific way lupus presents on darker skin that most physicians are never trained to recognize. And fourth, the downstream consequences of delayed diagnosis and what you can do today to change that trajectory. You have probably heard the word lupus before. You may even know someone who has it. But there is a strong chance you do not fully understand what it actually does inside the body. And that gap in understanding is one of the reasons this disease causes so much damage before it is caught. Let me close that gap right now. Your immune system is built to protect you. It is designed to identify threats, viruses, bacteria, foreign invaders, and destroy them. Think of it as the most sophisticated security system ever built. But in lupus, that security system turns on the building it was built to protect. The immune system begins producing proteins called autoantibodies. These are antibodies, normally the soldiers your body sends out to fight infection, but they are misdirected. Instead of attacking bacteria, they attack the body's own healthy tissue. They attack the DNA inside your own cells. They attack the lining of organs. They trigger inflammation in places that are supposed to be calm. And because those organs are everywhere, the kidneys, the heart, the brain, the lungs, the skin, the joints, lupus does not sit in one place. It moves, it flares, it hides, and then it comes back, often worse than before. Now here is the part nobody explains clearly enough. The inflammation that lupus creates is not just painful. It is destructive in a way that compounds over time. Every flare that goes untreated or undertreated leaves behind a little more damage. Not visible damage from the outside. Structural damage, scar tissue forming on the kidneys, thickening of the walls of the blood vessels, inflammation embedding itself in the lining of the heart. This damage accumulates, and the longer the disease goes without an accurate diagnosis, the more damage has time to build. Researchers published data showing that the average time from the first symptom of lupus to the correct diagnosis is 47 months. That is nearly 4 years of a disease moving through the body uninterrupted. For some people, it takes 6 years. For Black women, by the time that diagnosis comes, the disease has often already reached organs. 1 out of every 2 adults with lupus will develop kidney disease. But in Black patients, the progression to kidney failure is 9 times greater compared to white patients with the same disease. Read that back. 9 times greater. That is not genetics alone. That is the compounded effect of a diagnostic system that was not designed with this community in mind, and a disease that has been allowed to run too long without the right intervention. Now let me talk about why Black women face this disease at the rate they do. Because this is where the biology becomes essential, and where this community deserves more than vague generalities. Researchers have identified more than 50 genes that appear more frequently in people with lupus than in people without it. Among these, certain immune-regulating genes, including variants in IRF5 and STAT4, appear at higher frequencies in populations of African ancestry and are associated with elevated immune system activity. Think of these variants as an immune system that runs a little hotter. That heightened immune responsiveness is not a flaw. Historically, in environments where exposure to infectious disease was high, a robust immune response was a survival advantage. The biology we carry is not broken. It is a legacy of adaptation. But in the modern context, that same responsive immune system, when it misfires, can turn inward with more intensity. There is also a hormonal dimension that is too often skipped in the standard explanation. A global study conducted decades ago found that estrogen levels are measurably higher in women of African and Japanese ancestry compared to women of European ancestry. Lupus is strongly associated with estrogen-driven immune activation, a specific arm of the immune response called Th2 signaling that estrogen favors. 9 out of 10 people with lupus are women, and the peak years of diagnosis fall squarely during the reproductive years, between 15 and 44. When you combine higher baseline estrogen levels with genetic variants that already prime the immune system to respond intensely, you have a specific biological picture that the medical literature has documented for decades, and yet the conversation almost never reaches the patients who need it most. If you have been following along, and you are wondering whether someone in your family, or maybe you yourself, might need to pay closer attention to this, hold on to that question. I want you to drop a comment below and tell me, has anyone in your family been told they might have lupus, or struggled with symptoms that never got a clear explanation? Because the more we share what we know across this community, the more lives we protect. And if this video is giving you something you did not have before, make sure you subscribe so you do not miss what comes next. There is so much more we need to talk about together. Now, the diagnostic gap. This is the part I need you to hear with full attention. Lupus is sometimes called the great imitator. Its symptoms: fatigue, joint pain, hair loss, fever, brain fog, swollen lymph nodes, mouth sores, look like so many other conditions that physicians routinely mistake it for rheumatoid arthritis, fibromyalgia, thyroid disease, depression, or simple stress. 63% of lupus patients report being incorrectly diagnosed at least once before getting the right answer. 55% saw 4 or more different doctors before anyone named it correctly. But there is a specific diagnostic failure that falls hardest on Black women, and it is tied to something called the malar rash. The malar rash is one of lupus's most recognized signs. It spreads across the cheeks and the bridge of the nose in the shape of a butterfly. In medical textbooks, in training programs, in clinical reference materials, this rash is almost universally shown as a distinct pink-red flush against pale skin. It is recognizable, unmistakable, and easy to identify in that context. On darker skin, it looks different. On melanin-rich complexions, the rash may appear as a subtle darkening, a patch that resembles hyperpigmentation, a slight change in texture, or a faintly uneven tone that could easily be attributed to sun exposure or a skin condition. It does not announce itself the same way, and a physician who has been trained only on the lighter skin presentation of this rash can look directly at it and see nothing unusual. A study published in Arthritis Care and Research in 2024 found that approximately half of SLE patients report an initial misdiagnosis, with a diagnosis delay of 2 years on average. A qualitative study of 41 United States rheumatologists found that diagnostic shortcuts based on the demographic profile of who they expected lupus to look like contributed to both delayed and missed diagnoses. The system has been calibrated to look for lupus in a certain image, and when the patient in the room does not match that image closely enough, the disease hides behind clinical blind spots. She had been going to the same primary care physician for almost 3 years. Every 6 months, a new symptom. First, it was exhaustion so deep she had to sit down in the middle of cooking dinner. Then it was her knees swelling and stiffening on cold mornings, in ways that made her feel like she had borrowed someone else's body. Then the hair. She found it on her pillow in the mornings, on the shower floor, in her hands when she ran them through. She mentioned all of it, every appointment. And every appointment, she received the same response wrapped in different language. She sat in that exam room and thought, if I push back again, will he think I am being dramatic? And so she adjusted. She minimized what she was feeling. She said, I have been a little tired, instead of, I cannot function some days. She went home and told her sister she was probably just stressed. She took the supplements she was recommended. She kept going. And for 3 more years, the disease continued doing exactly what untreated lupus does. That is not a story without a name. That is a pattern with a name. And the name is diagnostic delay, and it is documented in peer-reviewed literature as disproportionately affecting Black women with SLE. Now let me tell you what that delay costs, because this is where the numbers become personal. The Lupus Foundation of America has documented that Black women with lupus die up to 13 years earlier than non-Hispanic white women with the same disease. Lupus is a top 10 cause of death in Black and African American women between the ages of 15 and 44. Black women with lupus are more than 3 times more likely to develop kidney failure and die from lupus compared to white women with the disease. And a study published in the Journal of Rheumatology in 2023 found that the risk of cardiovascular disease in Black patients with lupus is 19 times higher than in non-Black patients within the first 12 years of diagnosis. 19 times in the first 12 years. That is what delayed diagnosis costs. That is what happens when a disease moves through the body for 4 or 6 or 8 years without the correct treatment, without the monitoring, without the intervention. The damage accumulates in silence, and then it speaks loudly in the form of kidney failure, in the form of heart attack, in the form of years lost. And here is what compounds all of it. Research from the Black Women's Experiences Living with Lupus study, which followed 427 Black women with validated lupus diagnoses in the Atlanta, Georgia metropolitan area, found that greater frequency of racial discrimination in everyday settings, including medical settings, was directly associated with higher lupus disease activity and greater organ damage. The experience of discrimination is not just emotionally harmful. It is physiologically inflammatory. It drives the very biological mechanisms that make lupus worse. The system that delays the diagnosis is the same system that worsens the disease. That is the full picture. And now you need to know what to do with it. First, know the full symptom picture for your body. The butterfly rash across the nose and cheeks that may look like a patch of hyperpigmentation, a subtle darkening, or unexplained changes in skin texture. Fatigue that does not respond to rest. Joint pain and swelling, particularly in the morning. Hair loss in patches or diffuse thinning. Mouth sores that come and go. Fever without infection. Sensitivity to sunlight that produces a skin reaction. Protein in the urine, which you may only discover through a urine test because many people never feel it. Foamy urine or swelling in the ankles and legs can signal kidney involvement. Write these down. Keep track of when they appear and how long they last. Second, ask for specific tests. When you see your physician, ask for anti-nuclear antibody testing, ANA, which is the standard initial screening for lupus. Anti-nuclear antibody testing is positive in the vast majority of people with SLE. Also ask for anti-double-stranded DNA antibodies, complement levels, a complete blood count, and kidney function tests, including urinalysis. These are standard. You have the right to ask for them. Third, if your physician dismisses your concerns, request a referral to a rheumatologist. A rheumatologist is a specialist in autoimmune and inflammatory diseases. They are trained specifically to diagnose and manage lupus. You do not need to wait years for a referral. You can ask for one directly. Fourth, know your family history. Lupus and other autoimmune conditions can run in families. If a female relative on either side has lupus, rheumatoid arthritis, Hashimoto's thyroiditis, Sjogren's syndrome, or any other autoimmune diagnosis, tell your physician. This history is clinically relevant and belongs in your medical record. There is something important I want you to understand before we close. None of what you heard today is meant to alarm you. This information is educational. It is not a diagnosis, and it is not a substitute for a conversation with your own physician. What it is a foundation. When you walk into that appointment knowing the questions to ask and the tests to request, you change the dynamic of that encounter. You are not waiting for the system to catch up to your body. You are walking in already equipped. The body responds to accurate information at any age. The studies on lupus outcomes show consistently that early diagnosis, catching the disease before it reaches the kidneys, before it reaches the heart, dramatically changes the trajectory. 13 years of life is not a small number, and the research tells us that those years are not lost to the disease itself. They are lost to the gap between when symptoms begin and when the right diagnosis arrives. Closing that gap is not a small act. It is a profound one. Here is your challenge for this week. I want you to pull out a piece of paper or open a note on your phone. Write down every recurring symptom you have experienced in the last 2 years that never received a clear explanation. Fatigue, pain, hair changes, skin changes, anything that you mentioned to a doctor and left without a satisfying answer. Bring that list to your next appointment, and at that appointment, ask 3 questions. Could this be autoimmune in origin? Should we run ANA testing? And if so, will you refer me to a rheumatologist? Notice how the conversation shifts when you come prepared. If this video gave you something you did not have before, share it with one woman in your life who needs to hear it. Like it, subscribe, and tell me in the comments, what symptoms have you or someone you love been carrying without an explanation? You might be the reason someone finally gets an answer.